Okay, Dr. Seung-Jung, can you hear me?
Okay, all right. Good morning, everyone. So, welcome to Complex PCI's 2016 Technical Forum A2G. I would like to first of all thank you all of you to join and attend today here. Celebrating this is very first meeting. It's great pleasure to have all distinguished faculties and experts to this meeting. As you may know, yesterday we had a very exciting evening symposium, so future current concept to the latest technique in coronary intervention, and spent a great time discussions on what really matters, on what technique was, concept for intervention cardiology. Actually, today we had lots of cases. Maybe it's more than 20 cases, diverse cases to demonstrate, lectures and presentation, and discussing comprehensive issues on why and how to do PCI in current practice and its future facing interventional cardiology today. And I hope you all enjoy this meeting and stay in Seoul. And so this is very only first cases I enjoy with Dr. Jung-Min, Kang Seung-Whan, our fourth year fellow Dr. Soo-Jin Kang is here, and as always we have a distinguished team in Asan Medical Center. So I'd like to introduce first case, Dr. An.
Yes. Good morning, great audience. This is the first live demonstration case. This is a 76-year-old male admitted for default chest pain. Actually, he was performed the PCI at the proximal LAD, proximal LCX, distal LCX 6 months ago. But even after receiving the stent implantation, he still suffered from chest pain. So we performed the coronary angiogram, showed the diffuse stenosis of RCA and calcified stenosis of LAD. RCA was already treated with 2DS. So today we are performed the LAD, mid-LAD, very calcified critical stenosis lesion.
All right. Actually, can you see the angiogram in the auditorium?
Yes.
Okay, good, perfect. So actually, the 6 months ago, the proximal lesion was treated in another hospital, and however, there are mid portions, the top lesions, actually could not be treated. The reason why, actually, is very tough, calcified regions in the mid portion, and so JT with the stent proximally. However, mid portion just a little bit alone. So we met the patient with quite unstable symptoms, and I want to fix this, calcified lesion subset, and so I would like to shortening my turn. Would you show us the next view? So from the beginning, actually, I plan kind of rotablation for the. We cannot handle anything, and even the guide wires cannot pass the region itself, and so Dr. An used the microcaster and passed the rotor wires. I planned the rotablation, and then we didn't do any balloons, any imaging casters cannot cross the region itself, and so we just tried the rotablations from the 1 to 5, very small spur, and very gently. All right, Dr. Santos and usually talk to us, during the rotablation is don't too much push it. However, you have to push it, right? Very balanced, issues. However, I would say when he did rotablation, the RPM, rotation speed is 200,000 RPM. And so the speed is limited by the number of RPM. So I don't want to, decrease less than 180,000 RPM, something like that. And so slowly push it and push them back, force them back. And so we tried 1 to 5 force. It works, it's successful. And next. There's some part of plaque breakdown, and after the first burr, 1 to 5, there are more, anterior patency. However, some, Okay, we tried 1.5 burr. So next, the second burr rotablation, it very slowly touch it. Very distal part of lesion is quite difficult to pass the burr. And however, we push. All right, we can make it, and then all right, okay, all right. So this is the next step, and so. Actually, what I want to do, would you show us the first pictures and the very much calcific lesion? What I plan, very much calcified region, and depending on pre-dilation, so if we use the non-compliant high pressure inflation, etc., how can make a pre-dilation? That is the main issues, right? So. 1.5 burr, I think, is quite enough. However, I want to make a more maximal debulking. The meaning is I want to make some more, good figure of pre-dilation, pre-plaque modification. And so I plan 1.75, a little bit bigger, bigger, for rotablation too. So after that, we want to discuss, okay, I would like to advance a little bit further. All right, come on. Some resistance here. And so I want to change the high pressure and very slowly. Okay. Flat rotablate with a calcified region. Okay, I don't want to too much push it up to the, I don't want to decrease, number of RPMs or less than 100,000, 180,000. The meaning is high speed can make quite a good, small plaque disruptions, breakdown. However, low speed can make a big emboli debris too. So, okay, so finally we did 175 YN2. Okay, good, perfect. Finally, we did 175 burr, very much calcific lesion. So,
Sorry, SJ.
Yep.
Good morning, SJ.
Yep, I can hear you. Right.
This is Dr. Wu speaking.
All right.
One of the questions is regarding the rotablate size because you started with 125 is good, but you actually using a 3 burr for this procedure. But of course, you step up with only 0.25. That is good. You can kind of get rid of slow flow. But however, cost also nowadays is very concerning. So my concerning is if we want to save money, maybe 125. But actually, when I see you 175 after 1.5 burr doesn't seem to have a lot of
absolutely
polish. It's only it's just polish. So sometimes we just stepping with 1.25. If you don't think it's enough, you might get up to 175. Because one of the discussions is regarding DS error, how big burr to arterial ratio we should go, because from the bare metal stent era, we know that we very aggressive debulking that might increase the chance of deceleration, slow flow, procedure, MI, peri-procedure MI. However, does not reduce the restenosis. But in the DS era, there was a comment, might be we can use a burr to arterial ratio 0.5, 0.6, maybe enough, because your goal is only to actually cracking that the superficial calcium, we can achieve complete popping. For example, you have a ring calcification, you have at least 2-3 cracking after high pressure volume. So what is your goal for usually, but from the baseline, the reference vessel, your goal would be 0.5 or 0.6? That is one of my questions. And
great, Dr. Wu. Really, thank you for the comment on that. As exactly I don't believe too much. Okay, Dr. You want to do that? I don't believe too much about effect of debulking in the area of dilatation stent, and in terms of lay loss concern and clinical outcome concern. However, I didn't tell you about this case is very tough calcified region, right? And I don't believe how much degree of debulking. However, for particular these cases, I would plan is in a very inappropriate way of thinking. However, what about the BBS? You did lots of BBS cases, right? So we have some current practical guideline concerns, young ages and soft plaque. And however, I would try in a gradual burr and maximal debulking and appropriate predilation, and then after that we can decide which DS and which BBS, would be appropriate. Exactly what I totally agree with you. In the other real practice concern, I didn't do the 3 burrs, however, today's, demonstration, course, and so I don't care about too much money or concern. However, anyway, in a real practice, we didn't do that. However, particular for these cases, why not? I really stimulate you, or even in the, heavy calcific lesions, so we can dilate, pre-dilate, pre-modification of the plaque. Why not BBS, right? So that's the real, concern. Okay, why not? We're going to do the high pressure inflation.
3O, high pressure.
Yep.
Yang This is already a heavily calcified lesion. What do you expect you put the BBS after in this heavily calcified lesion? Dilate after resolving the BBS?
I don't know.
In this heavy calcified lesion,
I
what
don't
do you
know.
expect?
Okay, I want to show IVUS. Is not IVUS?
Yes.
I'm sorry.
Okay.
All right,
I'd like
IVUS.
to show IVUS first.
Okay, the meaning is even in the very superficial calcification on the plaque. Okay, well, why not? However, look at this. Any data, so we don't have any calcification, cannot make a good clinical outcome, something. The pre-modification, I think, is more important. So
Yeah,
superficial
I
calcium
agree.
is removed, and if the region could be dilated, why not? We're gonna do that, right?
I agree that preparation is very important for every stent, but in this lesion, in the fluoroscope imaging, there is a severe calcification, means that there is a calcium even in the superficial calcium as well as the medial layer.
All right, we're gonna see that. Oh, so you're gonna see
Yes.
the iris, right? Okay, good point. However, clinical endpoint, I don't believe anything about calcific. How to do is more important in terms of a calcific lesion concern. Okay, because after the 175 5 burr, the minimal lumen is quite getting big. This is almost a normal looking areas here. Reference vessel diameter is 2.7 something. And if you look at this is the worst part.
No, here is worst part.
All right.
Worst part is coming.
Dr. Kang, would you explain that?
Okay, this is reference segment, the 2.8 millimeter vessel, and it is the target
o'clock?
segments. And you can see some calcium cracked because of the rotablation previously done. And it is also soft plaque with attenuated plaque. And the lumen is still very small, but getting larger at the proximal reference segment. This is the reference segment, proximal located, and the lumen size is more than 3.5 millimeter.
So, as you've seen in the, this is a stent,
Lens,
right? Inside,
yeah.
I don't too much concern about this one. If you look at the lesion itself, there are lots of breakdown of the 9 o'clock, 8 o'clock, and 175 were passed, and then remaining plaque characteristics itself, not so too much tough. All right, there are calcific, fluoroscopic calcifications, etc., etc. What does it mean? So, anyways, meaning is I want to decide, imaging guide, and then pre-dilation with a 3O balloon first, and then we're gonna decide. Okay, why not DS? Simply DS. It's okay. It's a practical point of view. However, I would.
Any comment from the panel?
Do you want to implant BVS or DES to the valve?
After predilation.
Because of
It
course,
won't.
calcium is an enemy of all of us interventionists, and I completely agree with you to upsize the burr from 125 to 1.5, 175, because I know that if you use straight to bigger burr, jump into the bigger burr, there is always a chance of creating a larger particle. Of course, in this particular case, the lesion is rather short, but if the lesion is rather long, then we may have problem with slow or no flow reflow phenomenon. And then we also know that with rota, we normally get a smooth border and a slightly larger vessel diameter with a smooth border, relatively smooth border, as compared to if we do angioplasty or PCI, where we usually induce a dissection. So again, lesion preparation is very important. But in this particular case, the arc of calcification is not that extensive. I mean, less than 270 degrees. So I do believe that the lesion preparation would be very easy after 1.75 millimeter burr. So in this particular case, maybe we can implant BVF if you want to implant BVS after proper lesion preparation.
All right.
Hello.
Thank you.
Yeah, hi. Dr. Park, this is Dr. Adiraju from USA. Yeah, there is one approach I have been doing, especially in the cost containment era and, BVS situation, to actually have a hybrid approach to modify plaque, to use one burr and then cutting balloon. Cutting balloon after one pass with rotablator modifies the plaque a lot better than to use multiple burrs and dilate. So it's a one burr pass followed by cutting balloon modifies the plaque much better.
Okay. I think it's another option, right? However, but for the DS, it's a strong radial force, and you know that. I think it doesn't matter. It's a 125 and non-compliant balloon, it's a cutting balloon, it's okay. However, I plan, to be honest, from the beginning, I want to make some issues, and so heavily calcified region and gradual maximal debulking, and then predilation can make it a little bit more, appropriate approach for the PBS concern. And so I totally agree with you. Another option. So all right, that is the PBS. We tried 28 millimeters, and I want to. Okay, I look this one. Push a little bit. Okay, stop. Okay, I want to push the guide here. Okay, good. Quite enough, right? And then well matched between the stent distal strut and the normal looking area. And so I want to try the very low pressure. Why not inflate 6 gradually? This is polymer, so it's totally different with the drill stent. Okay, 6 is quite enough. All right, you want to wait. I think it's for the predilations with a non-compliant appropriate. All right, this is first. All right, so we spend at least 20 seconds. So the long duration inflation, I think, is more important rather than the high pressure, etc., etc. So 3.5. If you look at the proximal part, there's not too enough dilation in terms of a balloon itself, balloon delivery system itself, and the stent itself. This is polymer, okay, deeply. And so
This is 2.5?
No,
What
3.0.
size of?
3.0. 3.0,
Dr. Park?
28, yes.
But Dr. Park, this specialist is the proximal disc size discrepancy more than 1 millimeter. How can overcome the size discrepancy?
All right.
Because the proximal is already 3.5, distal part is 2.8.
All right.
How can overcome it?
All right.
If
So we.
one BBS or 2 BBS, different
Oh,
size.
no.
Which is
One BBS is quite enough, right? One BBS is quite enough. All right, there are still some, what do you think? Okay, calcified region covered?
Yes.
Covered on the,
Yeah.
okay, why not? We're gonna do the 3-0 high pressure inflation over distal part and 3-5 for the high pressure inflation in the proximal part. 3-0, previous 3-0, okay, we got a balloon here.
I think this is a very, very good demonstration of VBS because you need to very good preparation, the lesion, rotablator, and after that we use non-compliant balloons, very aggressive dilatation. You can see that even, I don't know, this is A French, right? Dr. Park, as usual. This is a French guide.
Yep, I like
A
it.
French guide, and you still see some difficulty in pushing through that well-prepared lesion. So you need some,
Right.
sometimes we need some push and forward. So, but this is a good demonstration that how, the size of a bar key
Stop it,
device,
stop it.
you need to be very aggressive.
Right.
Especially, like me, I'm doing a translator. Sometimes we
All right.
need a very aggressive dilatation. Otherwise, your deployment will be a trouble.
So our colleagues in the next cases, we discuss a lot about the PBS implantation. However, if you look at the distal dot, actually we cannot clearly see the polymer itself. The distal dot and the balloon match it and inflate, 3-0, high pressure. What is nominal? I think it's 14, quite enough for the distal part. And then, okay.
How much pressure? Nowadays,
14.
the able suggestion maybe you can go aggressive because after the TCT we have cross-door discussion, and Antonio suggests we should dilate the lesion if you're non-compliant more than 20. That should be the routine his practice.
All right. However, we got ideas of what the size would be. The reference vessel diameter is media to media is 3-0 for distal part, and so I don't know make any more. So we did apply the 16. However, proximal part is a little bit different story, and so pulled out a little bit further balloon out. Okay, a little bit, and the proximal part. Okay, we're gonna change our balloon. However, we're gonna try the high pressure inflation almost 20 and 25 atmospheres, still, under size less than 3.5 millimeters. We can inflate the 3.5 something. And so we apply there almost 20 and 24 atmospheres and for the proximal part. However, I don't want to make any, dissection or digest the distal part of absorb. Okay, deflate.
So this is a semi-compliant balloon?
No, non-compliant.
Non-compliant.
High pressure. All right. So you're gonna see that. What's happened? And then, okay. I don't push too much either. All right. Getting better. Actually, the basically distal part is diffused. However, we found some landing zones, a normal looking area just between the two. And in terms of a proximal part, we're going to try the 35 non-compliant balloon, right? Okay, why not? 35. And then we're going to show the how good the polymer oppositions, observer opposition to the vessel wall. That is our plan.
What about distal part of previous stent? It looks like it's underexpanded. Just the proximal
I
part.
enjoy your live demo very much. In my hospital, if I encounter with patients with heavy calcifications, after lesion preparation, I always do usually OCT because even if we have remaining calcific nodules,
35.
it can be disastrous.
14.
So
What is
even
nominal?
small focal localized calcific nodules
16.
can be very hard to dilate. So we have to be very careful with that, and then do more lesion preparation. Of course, in your procedure, I saw that there is no waste before you implant the BVS, and that's one important remark for you. And the other thing is that if I do post-dil, normally I choose quarter size bigger than the PVS size. With this, of course, non-compliant balloon. With this, normally we can get the vessel more, the scaffold more circular, and even we can get a better scaffold diameter, MSA, and also many of the stents will be well opposed to the struts, well opposed to the wall, and also we will have less strut malposition. Of course, as you said, we should not exceed the recommended optimal diameter.
So Santos, what do you think? This is final.
Has to be less than 0.5 bigger.
This is final result. What do you think?
Excellent.
5 BBS. All right. I'm satisfied. The reason why this is really, however, we want to show that what's happening in the inside in terms of polymer opposition, etc., etc. And so still, lots of issues. It's really, PBS is ready to use in the daily practice. It's more complex region subset, etc., etc. And however, we know that what it is. This is the first generation, still is not a perfect one, and I don't want to perfect anything. So, however, if we got some concept, I think we can use in any, complex region. So if you want, if we have some, okay.
Yeah, this is
distal landing is perfect, I think, right? Almost 3-0. Not too much matter opposition. And if you look at the worst
and this is typical for the struts. You see parallel lines of the PVS struts. Very typical.
So, Dr. Kang, what do you think?
Yes, yeah, you can see the double-layered struts, so it's scaffolds. And even though IVUS cannot show every single strut, it can show the optimal area and other complications. And there was no significant residual plaque burden at the reference segment, and the expansion is so good, and at least more than 6 square millimeter. Here, more than 8 square millimeter. So far, expansion is very good.
Following that, Taegu's recommendation, because it's a live demonstration, probably if not the cost limits, probably people would like to see OCT more precise and see the box, and you see how much you embed into the plaque.
Okay, so
my comment.
in the I want to show really real real cases a lot, and so I really moved to the second lab, and this is the first simulating cases. However, we want lots of cases, and so we want to show in the latest OCT findings, briefly. And so we want to move another lab, right? Thank you.
Okay, thank you very much.
Okay, thank you very much.
Right.
Let's move to the second lab.
Let's move on to second lab. Dr. Go, can you hear me?
Yes, I can hear you. Good morning, everybody.
Okay, go ahead.
Okay, so it's great to see you here from Asan Medical Center. So let me introduce our team first. So that my first assistant is Dr. Do-Young from Asan Medical Center, and we invited Dr. Jung-Sun from Severance Hospital for the imaging assistance. And Dr. Kang will introduce the case for you. Dr. Kang, please.
Yeah, thank you. Good morning, ladies and gentlemen. This patient is a 58-year-old female admitted for info chest pain. She has a history of hypertension and dyslipidemia. She has been treated with medication for angina since 2 years ago. She was admitted for recently aggravated chest pain and diagnosed 2-vessel disease with left main disease on CAG. Right coronary artery was treated with 4 DESs, and staged PCI and LAD disease was planned. Next. Her echocardiography showed normal result. And next. We will treat left main to LAD lesion. And today's teaching point is how to treat diffuse long lesion with tertiary stick and treatment strategy for left main disease involvement. And this picture is the baseline coronary artery of right coronary artery, and after PCI, we treated with 4 drug-eluting stents. And today,
So right coronary artery diffuse, very heavily angulated with some calcification, was beautifully treated with the several-eluting stent. And my task today is to treat the very long diffuse left main to LAD stenosis. So can you see and now you can see the first angiogram we are taking. So this is a femoral approach, and we are using 7 French XP sidewall guiding catheter. As you can see, the anatomy is very complicated, so that the very tortuous bending segment, and the ramus branch is very big. And you can see that there's some disease in the LAD ostium, proximal LAD, and mid LAD, and also very diffuse lesion at the distal LAD in the hinge and bend segment. Next, please. And from this view, you can see that the left main ostial, or the proximal part of the left main, also has some angiographically significant disease, and due to the overlap of the several tortuous vessels, it is very difficult to see the proximal and mid LAD lesion. But from this view, at least proximal LAD is, you can see that the mid LAD lesion is very tight, and there's a moderate stenosis at the hinge segment. So here is the angio we've taken for this procedure. So is there any questions and comment for this case from the panel? And if you want, we can show you the IVUS.
Can you show spider view?
Spider view was taken yesterday, but you cannot see you can't see anything further from the spider view because due to the overlap.
Okay. So left main ostial disease and proximal LAD to mid diffuse stenosis.
Yes.
So any comment from the panel?
Did you see the imaging? So
yes. Okay. So that Dr. Kim will show you the images.
Yeah, we pull back from the
So
intermediate.
can you show the IVUS images?
IVUS image, please.
Okay.
Yeah.
Go ahead.
Yeah, we did the 2 times pullback from the intermedius, and the other is from the distal LAD. Let me first show the pullback from the intermedius. Can you see the image?
Yes.
Yes.
The distal part of the intermedius is reference diameter was 2.6. Then we also checked the bifurcation region.
So the circumflex is coming from the ramus branch.
Yeah, here.
And
So this part is ostium is quite well opened, and the plaque burden is located at the opposite part of the ostium. So we can when we cross over the left main to that proximal LAD, I think there is a little chance to jail this intermediate branch. So the other one is from this LAD.
so the reason why we perform the ramus IVUS first is that I want to evaluate the left main lesion, but I was afraid that we may fail to advance the IVUS catheter through those tortuous lesions. So that's the reason why we perform the ramus IVUS first, to assess the ostium of the ramus and to assess the distal left main and the proximal left main disease. But we fortunately performed the IVUS from LAD2 as well.
So this is a pullback from the distal LAD. So this is a distal part of the tortuous distal LAD part. So distal part is reference diameter was 2.7, but there is some negative remodel. This part. So distal landing zone here, at the this part, there is a septal branch coming from 0 o'clock. So reference diameter was 2.7. Then we pull back. There is some negative numbering and attenuate plaque here, and then proximal part landing zone is here. Then reference diameter was 3.5. And this part, there is a calcification at the proximal LAD, and there is this part is coming from the intermedius,
this part. And
So LAD osteum also has a severe disease.
yeah.
Yes, so that there's no way to treat only the proximal lesion only, so that we have to treat the LAD osteal lesion anyway.
Yeah, this part is a minimal lumen area 3.1, and this part is a left main, and this is a left main ostium, quite eccentric. But lumen area was 5.7 square millimeter.
So practically the question was that it's okay to treat the proximal LAD lesion with stent, but where will be the distal landing and proximal landing? How can we fix the left main disease as well?
So this will be an interesting demonstration because if you can do FFR, then you can do, like yesterday's we have talked given from Dr. An, and they actually pull back and see which part is more critical drop, then maybe just fix that lesion first.
Yes,
and then you
yes.
can do, yeah.
So theoretically, that will be a perfect idea. But the problem we have is that the patient have proximal LAD very tight stenosis, LAD osteal lesion, distal left main lesion, and proximal left main lesion. So we have to discriminate the functional significance of 4 lesions. And even with several years experience of my FFR measurement, I will give up. And that's the reason that's the reason why I decided not to use pressure wire, even though I am a big fan of pressure wire and guided by the imaging for this case.
For example, if you put FFR into a ramus, that to see the significance of left main, is that theoretically good? Or
right.
bad?
So that but that value is also influenced by the very tight proximal stenosis. And the other practical issue is, even if left main is borderline significance, as there's a critical osteal lesion at the LAD, we have to cross the left main anyway. Right. So that even with the clarification with the physiology or the FFR, we have to treat it anyway. And when we implant a stent there, everything will be changed. So that that's the reason why practically, theoretically, we can do several physiologic studies and imaging studies and pullback, or the IFR scout may be helpful. But practically, I don't think FFR measurement in this case is not practically helpful, and that's the reason why we think that the procedure is make it simple and straightforward.
What about the left main osteo? You want to cover to the osteo, or you want just crossover from the mid shaft? They have a good landing zone to the the proximal portion.
So there can be several different opinions, but I think I have to fix the lesion to the ostium, because as you have witnessed from the IVUS images, left main has a very elliptical stenosis. So even it looks nice from this image, the lesion has a quite big plaque burden with a very elliptical stenosis. So that when we have to fix or implant a stent at the left main anyway, I think it doesn't be a big matter to extend the 10 millimeter to fully cover the whole plaque burden.
So Dr. Gu, one issue is quite different size of the discrepancy, the left main and LAD. So it might be needs 2 stents other than the 1 stent because of the very large discrepancy left main and the LAD mid portion. What about your opinion?
Right, so I think that's a very good point. So the issue really matters because that segment of mid LAD just before the hinge point, vessel size was 2.75, and the proximal LAD vessel size is 3.5, and LAD ostium, there was a little bit negative remodeling, and as you can see here, vessel size is 3.1, and the left main vessel size is 4.5. So and the lesion length in total was 50 millimeter. So our strategy was to divide the lesion into 2, and fix the lesion with the 2.75 stent to cover the proximal LAD stent, and try to implant the 3.5 stent with the overinflation of the left main part after stent implantation.
2.75 distal part?
Yes.
Because I think it's too small.
No, the vessel size.
You are shrinking.
The vessel size, yes. So in general, in considering if this is the proximal LAD, we have to implant the 3.0 or 3.5. But for this patient, the bending segment at that area, vessel size was only 2 millimeter. Maybe it's influenced by the accordion phenomenon or so. But that septal area, just distal to the lesion, vessel size was only 2.7, so that I don't want to implant the 3.0 stent to avoid from the possible injury or the perforation.
So that the first stent will cover the just behind the hinge area to the LAD ostium or left main?
Right, so that's another very important question. So that I plan to implant to locate the distal end of stent just proximal to that bending segment around the septal area. Because that bending segment, if it was seen by the different view, it's really tortuous and purely negative remodeling, and it wasn't very significant. From this view, you can see there's some disease, but it's not significant. So that my plan was to treat this lesion at the septal point.
Okay.
But the problem I had is that just after I had a trouble to advance the IVUS catheter, but just after IVUS images, the patient complains severe chest pain, blood pressure goes to 80, and the severe bradycardia. So we have to fix the distal lesion first.
Okay.
So that I'll show, yes, so that I choose the 2.0 millimeter balloon. Next.
Dr. Ko,
Yes.
this is Santoso. I don't know whether it's available in this country. In my hospital, if we have a long lesion, quite often we treat the long lesion with a tapered balloon. Tapered balloon has a very nice design. Proximally, the difference between the size between the proximal and distal end of the stent is 0.5 millimeter, but it has an open cell design in the middle and closed cell design in at the ends, proximal or distal ends. So you can still upsize the scaffold at the stent, and you can use from 40, 50, or even 60 millimeter stents with just a very long lesion with just one stent. And it is very trackable also.
Yes, I think that's a very smart idea to use that kind of tapered, because that coronary artery always tapered. But unfortunately, it's not available in Korea. I hope that we can use that device soon in the near future. Thanks for the nice comment. So this is the angio after balloon angioplasty. And we implant the 2.75. So that we had a big difficulty in advanced the guiding catheter, but pushing the guiding catheter a little bit deep intubation, and finally succeeded the implantation. To avoid the overstretch of the distal end, so I deployed with the under pressure and pulled back the balloon a little bit, 1 millimeter, and then fully implanted the stent. Next. Next. Okay, so next. So this is where we are now. So we implant a 2.75, and I don't think it's the size when you see the distal vessel and proximal vessel. 2.75 isn't a small stent, considering the very small stature of the patients. And now we are waiting for your decision for the left main stent implantation. So shall we proceed?
First stent is cover the ostium of left.
No, it's
no.
landed in the proximal part of the vessel.
Okay.
So are you going to check the IVUS from the Reims branch, the ostium?
So for what?
You're going to the crossover stenting,
yes,
from LMT to LAD.
Yes.
So maybe I want to know the plaque distribution of the ostium of the branches.
Yes, first IVUS shows you the IVUS pullback images from ramus to the main, Unfortunately, just distal to the ostium, there was some disease, but the ostium is almost free of disease, and there's some plaque opposite side to the carina. So that there's a possibility of the jailing, but the possibility of total occlusion may be low because there's not much plaque. And as you can see here from this IVUS images, the circumflex wire is coming from 2 to 3 o'clock, and plaque is mainly located from the 5 to 8 o'clock area, so that there may be some carina shift, but plaque shift may not be a big matter in this case.
Okay.
I hope.
But anyway, the jailed guide wire, you will do that?
Yes, so
ramus, right?
Yes, I will keep the wire to protect the ramus, because the anatomy of this patient is quite interesting, because the patient has practically almost no diagonal branch. So the ramus branch is working as an obtuse marginal and diagonal branch as well. So this is a very important branch, so I want to do the procedure in a safe way.
Yeah, I totally agree with Dr. Gu that the plaque morphology, location of the plaque in the bifurcation is very important to estimate the possibility of occlusion of the circumflex. Why don't you go ahead?
Okay. So the other issue we may have is that which is the best angle to see the ostium of the left main. So for this case, I choose the epicranial view, because from this view I can see the ostium. Okay, so let's try and fix the lesion. So
what is the length of your 3.5?
Yes, 3.5, 26.
26, okay.
Yes, there will be some overlap, but I want to have some safe margin.
Okay.
Because
depends on my practice, because RAO or epicranial is a good view. Sometimes depends on patient's anatomy. Aerial cranial also can identify the osteo very well. So will be a three common view I want to see if I have full coverage of lemon osteo. So that's as Dr. Gu's suggestion is you go with the epicranial view.
Okay, so let's see which angle is the best for this patient, because I fully agree with Dr. Wu's opinion, because sometimes epicranial, sometimes cranial, but sometimes elaeocranial. It depends on patient anatomy, so that we shouldn't say the one best angle, and it depends on the patient anatomy.
Yes, I think that for the left main ostium, if the view that you can see the upper wall of aorta and lower wall of the aorta, that's very important to get the optimal position of the stent.
Yes, I see.
So you can select the view.
Okay, so after advancing the stent, I will give some angio shot to see which is the best view. So I feel some resistance in advancing. So this is 3.5. So I'll pull back.
What stent?
What
stent?
Is it? It's onyx.
The onyx.
Regular onyx.
So
onyx?
Yes, there's no choice. So I was told to implant this stent because this is a good stent.
Sometimes you can see that you see an overlapping zone is somewhat difficult. So if we're not practice, because Dr. Gu is already pull back, go high pressure, but if some resistance, I might use a 3.0 to maximize that, the first stent, the proximal edge to facilitate your second stent to overlap.
Okay, so now there's a minimal overlap. And when I pull back the guiding catheter a little bit and give a test shot, as Dr. Chang mentioned, I can see the proximal and distal part of the sinus.
This will be only edge to edge. There's not overlapping. You probably need some advance
so
a little bit.
I will advance a little bit. I think there's some overlap. Test. So how do you feel?
That's good.
So do you want to have a different view, or it's okay to go ahead?
I'd like to try LAO.
LAO,
checking from
LAO a little bit.
LAO.
I think IVUS guided is very important for osteo lesion. You can use IVUS and then mark technique.
Okay.
And then you can make sure the exactly osteo implantation.
Okay, so how do you like this view? There's some overlap,
Okay,
right?
very good.
Very good.
Okay, so that with your permission, I will implant stent.
Can,
Okay.
can
Go
you
ahead.
let the guiding more close to the proximal edge of your stent? Maybe you can
Okay.
identify that exactly osteo better.
Stop. Deflation. Okay, this is 3.5. Okay, 10. Okay, AP cranial 다시 돌려주세요. I hope that I didn't jail that much of the circumflex. So I will gently push the guiding catheter. So gently pulling the balloon. And taking angio here. Just in there. Okay.
Okay, Dr. Gu,
Yes?
very nice. So Dr. Dogubak is eagerly waiting.
Okay, I see.
So we'll come back soon.
Okay, I
So
see. Please.
Now we'll move to room number 3.
Okay, thank you.
Thank you.
Okay, hello, good morning.
Okay. Would you introduce your case?
Okay, good morning, and panel and audience. We prepared this one of very interesting cases. And I'm gonna introduce our team. It's Dr. Joon and Chang and Dr. Hong. The interpret is overall the IVUS finding. Okay, Dr. Joon, could you introduce patient history?
Yes. This is a 62 years old male who admitted for the chest pain. And he visited to our hospital due to TNT positive result. And CAG showed the diffuse stenosis involving proximal to mid LAD and elective PCI for this diffuse LAD lesion was scheduled. Next. He has a risk factor of hyperlipidemia and the clinical diagnosis was stable angina. Next. The functional test showed the positive Termi test and baseline cardiac catheterization showed that the diffuse stenosis of proximal to mid LAD with the FFR value of 0.37 and the severe stenosis involving the T-cell circumflex.
Okay, look at the first coronary angio. So this patient was a 63-year-old male and presented with upper chest pain. It's clinically stable angina. Look at the post-angio view, and we have two regions in the circle region, intermediate region. We already randomed the plaque sealing trial. It's medication versus BVS prevented trial. So we put the BVS already. So it shows the region. So we put the 3.0 BVS 23 and the region, the procedure was successful. And then our target was the LAD diffuse calcified region. And the next, this is the cine view without the dye contrast, and you can find is how much the coronary calcification is present in the diffused LAD from the LAD ostium to the mid LAD. Next, and look at the epicranial view, and you can find it's a very diffuse region. Its calcium was very severe, and the region was extended to the mid and the distal LAD. So, and we are some very important point, and this diffuse long region, we first check the IVUS in how much decided the stent size, how much covered the overall the stent length, and we check the pre-intervention IVUS. And Dr. Hong, could you rapidly interpret the IVUS?
Could you show us the IVUS image? Okay, stop. This is distal reference. Lumen diameter is 3.0, and we can see some calcium and heavy calcified lesion and large amount of plaque, eccentric plaque. And this is vessel diameter is 3.0, large amount of plaque, some calcium, superficial calcium. You can see here calcified nodule, and large amount of eccentric plaque with superficial calcification. This is proximal LAD. We can also see the superficial calcium with large amount of plaque. A very diffuse long lesion with heavy superficial calcification.
Okay, so and we checked the LAD ostium. LAD ostium was intact, and the region was extended from the LAD ostium to the LAD. Our strategy is very straightforward. Just put the two or three long stent, and for this case, the region preparation is one of the most important the part, and in the contemporary the drug-eluting stent era, and there are many options for treat the region preparation in the scoring balloon and cutting balloon and non-compliant balloon and the rotablation. So for this case, we prepare the rotablation. And any comment from panel for this case?
So I want to ask that you are going to rotablate
Right.
Even in the mid part of the hinge portion?
No, it's just
You're
I'd like this the upper middle part.
Okay.
Yes.
What size of the burr?
The
do you
burr
try
is
to-
I select 1.5.
What is the cost comparing the rotablators and the, for example, cutting or score fracs in Korea? Because I see the some part chasm superficial is only about 180, but however, it seems like if you use a non-compliant balloons or cutting balloons or score fracs, I might expecting they have some reasonable cracking of that chasm. So if you compare with the cost, I don't know.
So, okay.
This will be one
how
of
much
my
cost in
concerns.
Korea? I don't know exactly the rotablation. The cutting balloon, non-compliant balloon is less than $300 in Korea, and the rota balloon was might be more than right? I don't know exactly the cost. So we select the guidance, jockeying the aid. I prepared the rotablate. I'm gonna do rotablation in the 1.5. Okay, the straightforward. At the pulling stage in the low pressure and the low pressure. 와이어 안 나오게 low pressure. 잠깐만요. 라이딩 살짝 나왔다. Okay.
So you start with 1.5 millimeter burr or 125?
1.5. Usually the recommendation is burr size is recommend is compared to reference vessel diameter less than 60% to 70% of reference vessel diameter was usually recommended. The distal vessel diameter was 3.0. The proximal is 3.5. Okay, this is the low pressure. Okay.
The lesion is very long. So in a very long lesion like this, there are several points that we have to remember. First of all, there is a higher chance of slow or no reflow phenomenon. So we have to advance the burr very slowly. Don't rush. And be rigorous in doing flushing with vasodilator solution, either intravenously or intracoronarily. And if necessary, take time. We don't have to rush because otherwise we don't want to induce a lot of problem with particles. And we don't want to have a slow or no reflow phenomenon. And I think that's very important.
Is there any cocktail solution in Asan Medical Center to prevent slow flow, or you just routine, or maybe heparin, verapamil, or some?
This is a packing maneuver is very important. It's like the butter eating like motion. It's a slowly packing maneuver like this. Okay, great. Okay, 됐다. Low speed. remove 해볼게. 잠그고. Okay. During the pullback, we're gonna keep the low speed. And 빼주세요. Low speed and low speed. And
The
the
other
low
important
speed.
point is we have to consider the left ventricular function. This particular case, if
Okay.
the left ventricular function is good, it's okay. But
Yeah, right.
if the left ventricular function is marginal, then we have to prepare inotropic solution for infusion in order to support, in order to avoid hypotension, because hypotension may induce no flow, slow flow phenomenon, especially in a very long lesion like this.
Okay, nitro. And we have the prepared the cell line infusion and the contrast type. We mix up of the adenosine and verapamil. And during the procedure, and there is some risk of the microparticle embolization, and so the pre-medication is important for this patient. Okay, test.
I think that key.
Some Japanese doctors use the low speed instead of high speed. So how do you think?
Completely agree to use low speed rather than, because with low speed we don't create large particles, and also using a smaller burn and upsize we can avoid having a larger particle embolized distally.
Okay.
I think the key point to prevent slow flow is important is speed and also advancing.
Right.
You need to be avoid deceleration. So, burn run time at the beginning, Rota, they recommended not to go beyond 30 seconds. But if you have a long lesion like this one, you might separate your burn run time. For example, 10, 15 seconds. You can separate 8 times or 10 times. That can reduce the chance of get the vessel to breathe somewhat, and that can prevent the slow flow.
Okay, at the high pressure speed, keep in mind is that you want to keep the speed, the RPM is more than 180 RPM at least. So this is the microcaster. We're gonna change it to the BMW long wire.
Dr. Santos? Dr. Santos? In this case, it's actually calcium's arc less than 180. Calcium arc. Half of vessel is actually normal. Yeah, so do you think this rotational atherectomy efficiency is good work in this situation?
Very eccentric plaque.
Yeah, very eccentric.
Well,
and
we can try.
Half of vessel is normal. So.
Usually in my hospital, and in order to save cost, I try the high pressure fluid first. Because the calcification seems not to be very extensive.
Whole area is diseased. Rotational atherectomy efficiency may be good, but half of vessel is actually normal. So in this situation, efficiency is very
But even in
poor.
the eccentric plaque, when you use the rotablation, you will see some part of the eccentric plaque will be debulked. But let's see with the IVUS in this case.
It will be interesting to see IVUS after debulking.
Okay, great. Okay, and then we're gonna try to put the protection wire. There was some big diagonal branch. Okay, test. Okay. 위에 밑에 보여주고 test. This is the Sion wire, and then. Okay, we're gonna quickly check the IVUS, how much the calcified region was, the breakdown is how status was mostly calcified region. Is Dr. Wee mentioned not the circular calcified region. Is some portion was not circular, but some portion was totally more than the 300 arc was calcified region, and so we're gonna check the IVUS. There is a what often was the calcified region. Okay, 위에 보여주고. Okay, 따라와. Okay, the IVUS was easily fast. Okay, full back here, and here we perform the rotablator. It's Dr. Hong.
Yeah, this is a lady. This is a lady.
Yes, this is the part of the
some spot
bifurcation
calcification
region.
here. you can see some calcium, superficial calcium. Some
This
crack
yes,
after
the
rotablation.
calcified region. The side branch was
branch.
coming. Okay, we have some time limit. We're gonna pull back the hand maneuver over here, over here. This is the proximal part. The added ostium was the nearly okay. This is the okay. 좀더 따라와.
I think Dr. Gu, because he
Yeah,
had
okay.
some
This is,
OCT experience using
okay, and
OCT to identify the calcium thickness and to guide how to use rotabrator properly. I think maybe Dr. Gu can give us some comment regarding this.
Yeah, right. So OCT is, you know, some as the most intervention list is already know. OCT shows the more detailed images, calcium, and the more detailed image plaque. The practical viewpoint is during the procedure, is OCT use is not practical for me. Is even though the Illumine-3 trial is scientific evidence is great, but practical evidence is most interventionist. The don't too much believe is Illumine-3 trial released the TCT a couple of weeks ago. Okay, and then I'm gonna do is a non-compliant balloon. This is a 3.0. Is IT side 3.0 balloon size is the 3.0. The 20 millimeter is a non-compliant balloon. It's IT
Okay,
side.
Okay, Dr. Dogubak.
Okay.
Another rota is waiting, so we'll
Okay,
come
great.
back soon.
Okay, got
so
it.
now we are moving to
Okay,
another
test.
room.
여기서부터지? 여기서부터?
Okay, Dr. Han, would you introduce your case?
Yes. Good morning again. Could you introduce the case?
Yeah, this is a 69 years old male patient, and he's admitted for upper chest pain. About 16 years ago, he underwent PCI at proximal and distal LAD separately, and mid RC also. And we also performed the functional test, and the treadmill test was negative, and the Thalion spec showed reversible large defect in inferior area.
So previously we performed the coronary angiogram, showed the total ISR diffuse disease of RCA stent. Code is 3.0 bare metal stent. So several weeks ago we performed the C2 intervention for RCA, and today I am preparing the LAD intervention. Could you show us the LAD angiogram? He had a history of 2 stent implantation to the proximal LAD and middle LAD. Another, yes, this is good. Can you see the stent?
Yes, what stent was that?
Yes, it looks like the
like GR stent?
Yeah.
Very old
GR
stent.
Yes, 16 years ago, he received the stent, 2 stent. The radio OPEC is not good. Just it looks like the BRS by observer. Yes, only 2 markers. So initially I tried, next. So I run. So initially wire insertion, and I tried to the IVUS evaluation, but at the portion of diagonal LAD bifurcation, guiding IVUS catheter cannot pass. So at that point, there is a very severe underexpanded previous bare metal stent. So for the lesion pre-modification, I did the rotablation. This is 1.5 burr using, so I did the region preparation, and then I evaluated IVUS. So Dr. Kang, could you show us the IVUS findings?
Yes. overall, you can see the lesion segment here. This is the second stent near the bifurcation site, and this is the proximal site, stent. And you can see the distal reference segment here, and let's get started. This is 3 millimeter diameter of the vessel, and some plaque is here. And this is some calcium, but this is the residual plaque burden and progression and edge restenosis. And the main mechanism of distal stent restenosis is under expansion. So stent area is less than 4 square millimeter, and it's definitely small. But there is no significant intimal hyperplasia, and the main mechanism is under expansion. And the proximal side, you can see the septarin diagonal branch, and there is no significant intimal hyperplasia and well-maintained stent area. So the restenosis is confined to the only distal part of the distal stent. And then you can see the stent gap here, and distance it was measured as 5 millimeter. And you can see the very severe plaque, and the vessel size is nearly 4 millimeter, but the small lumen area was here. And then you can see the proximal stent distal edge here. And it's very interesting because it has a different mechanism of ISR. So you can see the big stent, but there is a significant intimal hyperplasia that causes in-stent restenosis here. And the lumen area is less than 2.5 millimeter. And then you can also see the interesting findings, the in-stent calcium, suggesting the presence of neo-atherosclerosis in the old stent. And here is the very impressive findings. The stent is here, and neo-intima is here, and there is a superficial calcification of neo-intima. And this is de novo neo-atherosclerosis, and it's very old feature. And then you can see the proximal part of stent has a big stent area and minimal intimal hyperplasia, so there is no problem. And after here is the circumflex coronary artery, and the left main has some plaque, but there is no significant luminal narrowing.
Yes, there is a bare metal and ISR case. There is different mechanism of ISR. This stent definitely under-expanded stent. Proximal portion a little bit under-expanded plus neo-intimal hyperplasia. So, yes,
one of the questions is regarding before you IVUS cannot pass, did you try with balloon dilatation instead of directly change to a rotablator?
Yes, that is a good point. Actually, this is a live demonstration case, so we did rotablation first. But yes, I agree with your opinion. In the daily practice, I would try to first the balloon dilatation. Okay, so I like to receive your advice. Under-expanded small bare metal stent and neo-intimal hyperplasia, a little bit larger proximal stent. How to deal with these two different mechanisms, diffuse ISR case?
Actually, what size of the distal bare metal stent?
2.5.
So if you want to maximize the distal under expansion, better way is to use fractionatome, just cutting balloons, or because the cutting balloons actually can prevent the watermelon seed phenomena, and it actually now is quite a good compliance. You can go even some high pressure, so to try to maximize as much as possible. Skull-flex, I don't know, because the balloon can only, maybe Santosh can give us a recommend regarding that, skull-flex, because the maximum, limit is about 16, but sometimes it's very difficult to expand that unexpanded original 16 years, where I understand.
Yes. So is there any other opinion?
Okay, Dr. Wang, we'll come back soon. Dr. Gu would like to show final result. We are moving to Dr. Gu case.
Okay, welcome
Okay,
to our
Dr.
room
Go.
again. Okay, so that I can hear you. So as recommended, we implanted 3.5 millimeter, 26 millimeter stent with the minimal overlapping. And we post-dilated the ostial part of the proximal LAD with the 3.0 millimeter balloon with the non-compliant 18 atmosphere. And the proximal part of the left main, and the whole left main was redilated with the 4.0 millimeter balloon. And now I'll show you the IVUS images. Unfortunately, while pushing the IVUS catheter to the far distal, the wire catheter was broken, so that we use a new wire and showing only the proximal part. Okay, so that Dr. Kim, please.
Oh yeah, this is I was pulled back from the proximal LAD. Previously, we did I was pulled back before post dilation. At the time, proximal LAD minimal lumen diameter 2.4 and minimal lumen area 3.8. So we dilate again with 3.0 non-compliant balloon. After that, this is another pullback of the IVUS. As you can see, this part is minimal lumen area. Minimal lumen area significantly increased to the 5.2 square millimeter and minimal lumen diameter 2.8. So this is a final IVUS image.
So can you show the left main?
Left main. Left main ostium. This is a pullback.
According to the Asan's recommendation for the left main, 5, 6, 7, 8, so we probably 5.2 is not that satisfied for me because might be, I don't know if we are considering maybe a negative remodeling for the LAD osteo. Otherwise, I would be a little bit aggressive to dilate that LAD osteo because that is tended to be more prone disease maybe in the future, restenosis.
Right, so I agree with your opinion that we are just a little bit behind the 6, so 5 point something. But the one caveat of the additional, so we had a 3.0 balloon, 20 atmosphere over the limit. And when we dilate further, so that the vessel size was almost 3.0 before the intervention. And the other caveat of the post-dilatation may be we are going to jail circumflex more. So that's the reason why I'm quite comfortable with the 5.0 something because before, so we did 1.30 high pressure balloon, and at that time lumen area was only 4. Now we made more than 5. But considering this is because we are not treating the lesion with the 2 stent, so this is single stent, and when we apply the Asan data of rule of 5, so we reached over 5, so that I would like to favorable data from Asan Medical Center. So it depends which data you want to apply. So
So this is IVUS.
Cool. This is a very nice result. But allow me to give some comment to the audience regarding the technique to advance the guiding catheter after you successfully implant the stent covering the left main ostium. Because I saw that you tried to advance this back to the left main ostium. A good technique is that one thing that we are very afraid of, especially with the current generation stent where the strut thickness is around in between 60 to 81 microns, we are afraid of inducing concertina effect or stent disruption, especially in the ostium. So in order to prevent this, first, coaxiality is very important. And secondly, it is probably best to have the balloon positioned in the ostium or close, slightly protruded to the ostium, and then partially deployed, partially, don't fully deflate the balloon. So let the balloon half open, and then when the balloon is half open, we can advance the guiding catheter, maintaining the coaxiality into the left main. With this, we can prevent inducing concertina effect, especially if the takeoff of the left main is acute.
Right, so I fully agree with you. So that we should take big concern on the not damaging the the protruded part of the stent, as you can see here, so that I'm happy to see the full circle of the ostium of the stent.
Yes, of course. I saw it. Very nice.
So there's a one.
Dr. Gu,
Yes.
can you see the ostium of the ramus?
Okay. So did we take the
another projection?
Quarter view? Down. Okay. So I'll give a LA quarter. So it's not easy to LA quarter. So we perform the caudal. Okay, so here, maybe you can see. Okay, so there seems to be some osteal pinching, but it's not clear. So from several views, it's hard to discriminate.
So in this case, you try to do FFR?
Yes, if I have time. All right, so but even if...
Can you see the IVUS image? Yeah,
okay,
the opening of the...
Okay, so that Dr. Kim give a good hint, so that here's the IVUS images, although it is not 100% accurate, because this is a pullback from the LAD to left main, but the lumen seems to be fine. Right. So if you agree, I would not going to use another resource.
Sometimes opticross, because now it's very small profile. If the wire in the ramus has been recrossing, right?
Yes, yes.
So if the opticross can pass, I think there's no need to FFR.
Sure. But still, I want to measure FFR. But here, we decided to do the purely image-guided procedure, so that it's okay to use so that when we started with the IVUS and physiology-guided approach, I would definitely use the pressure wire. But for this, the question is whether we need to use another resource with all information we have. And for the education, of course, it's okay. But in general, I don't want to make things more complicated.
Okay, Dr. Gurs, I think you have a nice result, main branch happy, side branch happy. So I think you are very good job.
Okay, thank you. I hope you all are happy.
Okay, thank you very much.
Thank you very
much. We are moving to next room. Okay, Dr. Duk-Woo.
Okay, this is room number 3, and we did the rotablation, and then we put the protection wire for diagonal branch, and then we did non-compliant balloon from the distal LAD and the proximal LAD. Distal, they used the 3.0, 20, the non-compliant balloon, and then next, and then this is the post non-compliant balloon implantation, and next. And then we decide to the giant stent. This is the 3.0, 38. Put the one giant stent, and next high pressure. Next, this is another giant stent. It's a 28, 3.5, and next. And put the next. And then finally we put the 4.0 and 23 giant stent, and then next. This is the post-immediate image, and next. So we need more optimization of the stand, and next. And this is the non-compliant balloon 3.0, and from the distal end of stand, next. This is 3.0, next. And this is 3.0, next. 도포 마이크로 달고 3.0, next. Next. This is 3.5, next. Okay, next. Next, we did a 3.5 balloon, and then we finally do the 4.0 for the LAD ostium. This is a 4.0 non-compliant balloon. 도파민 조금만 다세요. 하이드레이션을 10 달고. 자, this is the 4.0 non-compliant balloon. Is exact positioning of a non-compliant balloon. The position is okay. Test. I'm gonna use the stem booster. Okay. 1, 2, 3, 4, 5. Okay. Can you show the stem booster? 아니 이걸만 하면 돼요. 누르세요. Okay. Look at the stem booster. Slightly protrusion of the proximal edge and the slightly push. Okay. Go. Nominal. 12, 14. Okay, deplete. Okay, and then check the angel. Okay, angel ready. Shoot. Okay, the result looks like good. This is the epicranial view. Okay,
What about total stented length?
okay, great. So
Total
total
stent-
stent length is 38 plus 28 plus 23. Is I need some time to calculate.
You calculate.
Yes. So and the side branch is okay, and we did the multiple non-inflation balloon dilation. Is flow is okay. So I finally checked the IVUS result, and most of interventional cardiologists already know the IVUS was much helpful to treat complex lesion, especially for the long lesion. And we have very nice data from IVUS EXL trial. Is last year published in JAMA article. Is IVUS is much helpful to treat the long lesions compared to angiographic guidance. Even in the complex lesion in the XL and Noble trial, in the XL 74, Noble 72% in PCI arm, to use the IVUS. The IVUS is very helpful to treat the complex lesion. Okay, start. Okay, slightly more.
This is distal lady
Okay,
stent.
okay, 조금만 더 들어갈게요. Okay, great.
At the distal reference segment. It is stent diameter is about 3. No tissue prolapse. You're going to the middle lady stent. This is very long lesion, so it's very difficult to interpret.
I think we have no enough time. I'm manually full back. Okay, this is the part, and this is the 원주만하고 the middle part, and the 3.5 was the implant here, and this is 3.5. This is a 4.0. There is some eccentricity, and here is pullback. Okay.
Proximal lady.
Yes, this is prox LED.
Elliptical.
Yeah, there is some eccentricity. We did already 4.0 non-compliant balloon. Several times.
This portion is underdilated.
Yes. Do you think so? I need more additional non-compliant balloon over that area?
Yeah, I agree with you.
Okay, there is some.
Distal part mildly underdilated, and proximal part is severely underdilated.
Okay.
Dr. Pa, what
yes.
is the, do you think is on-point bar rotablation isotomy is really necessary for this region? Because 1.5 bar is frame modification at the very short segment, but
yes.
the proximal part is a very big vessel.
Yes.
But even if you have the non-compliant scoring volumes, I think it is enough for this very long.
Yeah, right. So I think the middle portion of the calcified part is a rotablate is very helpful. The proximal part, even though we did a non-compliant balloon pre-dilation and the post-dilation, is I think the proximal added osteum part is too much work, but the middle part is LoRa work. And I think the final IVUS, we found some under dilation of the proximal part. I did some additional balloon using the 4.0.
So the proximal strat of the stent was, I think, a little bit malopposite
yes.
On the LMT wall. So why not you do the KVT for the to complete to get
usually
the
you know even though left main size sometimes the 6 millimeter or sometimes 6.5 millimeter, the stent is protruded slightly, even though there is some inner position. The left main part is the left main is size is very big. So we have some experience, a large experience. Even though the proximal strut is slightly protruded left main, is clinically it is not the influence of the long-term outcome. Is just the leave it alone would be overall okay during the long-term time. Okay, epicaudal.
I think there is a
this is
difference using the KBT between Japan and Korea. In Japan, they are using a lot of KBT. They cannot kissing balloon.
자, 이 정도. 자, 고 nominal. Okay, this is 12. Okay, deeply. 조금만 더 들어가자. 여기만 살짝 해봐. 4, 4, 5, 6, 7, 8. Okay, deeply. This is 4.0. Okay, go. 10, 12, 14, 16. Okay, deplete. This is 4.0. 좀 아프시죠? Okay. I'd like check the scene. Okay, 나왔지? 살짝 나와서. 자, 고. 18. Okay. Okay, deplete.
I think main is okay. LAD austere portion is severely underdilated. So probably
Not
you need
severely I don't think so. It's not severely
3.5 non-compliant balloon.
So we did the 3.5 and 4.0 several times. Even though there is some eccentric, the opening is if you're gonna do is totally fully expand the lesion, sometimes causes some perforation. I think even though eccentricity is lumen was okay, I think leave it alone would be okay. Is that we cannot make a whole lesion is a total concentricity. This is not feasible in the real contemporary practice. Okay,
Yeah, I agree with you. So just stop it for populations.
Some the severe calcified region is we cannot totally resolve the eccentricity. Okay.
Sometimes it's a trade-off between you have a very eccentric calcified plaque. If you see IVUS, you can see a symmetric expansion, but sometimes you too aggressive dilatation, you might have a chance to rupture another part. So this is I learned from my very aggressive practice. Sometimes I made a mistake.
Okay, here portion, I did the 4.0 non-compliant balloon. Did you find, is there any severe unexpanded region?
So far, the stand expansion is very good. Stand diameter is 3.5, more than 3.5. Stand expansion is good.
Yes, stand was much more. There is some eccentricity. Even though I did the 4.0 balloon up to 20 ATM, I cannot resolve this eccentricity.
Diameter is 4 by 2.5. Yeah. Elliptical shape.
That's the left main.
This is proximal radius. This is circumflex is coming.
This is
this is left main.
the distal left main. So we did several times non-compliant high pressure balloon. At the ostium there is still eccentricity. Can you measure the lumen area?
Proximal part there's some stand malposition.
Okay, even though there is some eccentricity, lumen area is okay for 6.7. I think this is at best I can do for this patient. I just finished this procedure. The proximal part of the left main stand was slightly protruded of the left main. If you're gonna thoroughly make a pose, we need more than 6.0 non-compliant balloon. Usually, slightly protruded of distal left main. It doesn't matter in on the basis of our long-term develop the left main result. So I'm gonna finish this procedure. I'd like check the final coronary angle. Okay.
So every branch alive?
Yes. Okay. Okay. Most
Okay,
of the
very nice
branches-
result.
Yes. Great. Thank you.
Okay, thank you very much.
Okay, thank you.
Okay, thank you. Nice demonstrations. We are moving to Dr. Han.
Yes, I'm Dr. Han. So I applied the 3O balloon, high pressure balloon, distal and middle.
We didn't see angiogram.
Okay, after the high ballooning, and then I will show you the angiogram and proximal portion. So could you show us the initial coronary angiogram? So this is initial coronary angiogram. So I applied the 3O high pressure balloon to dilate the underexpanded stent. But based on this angiogram, could you do that? Dr. Lee, recently you designed the angio-guided stent procedure. So I almost agree with your idea, but in this particular case, I definitely need some kind of IVUS evaluation. So based on the IVUS evaluation, I know I definitely have information about vessel size and stent size and length. So I can apply 3O high pressure balloon to the middle stent and proximal stent. I will show you the angiogram now. Okay, I think much better than before. And I already evaluated IVUS. Dr. Kang, could you show us the IVUS findings compared to the previous IVUS?
Okay. I will give you the IVUS images from this distal portion of the distal stent. Here is the well-expanded stent, and this is the previous side of minimal stent area. And the stent area is improved and larger than 5.5. So 5.9 square millimeter was measured. So it's very enough. And then we can move to the more proximal part of stent. There was no problem in the stent of the distal stent. And then this is stent gap. And you can see some minor dissection, but it was not more than 60 degrees. And the lumen, true lumen area is very good. And we can measure the lumen area at the dissection part, 5.5 square millimeter, quite good. And then we can move to the proximal stent. And the distal edge of the stent has a big stent area, and the intimal hyperplasia, the amount was significantly decreased because of the redistribution. And the minimal lumen area site was here. So you can see the stent and the remaining intimal hyperplasia here, but the lumen area was measured as 5.8 square millimeters. So in overall, the minimal lumen area was 5.5 square millimeter, and we have the quite good stent area and the minor complication as a small dissection.
Okay, thank you, Dr. Kang. We have two nowadays. We have two choices. The first is one more debulking stent implantation to cover the two previous bare metal stent. The other choice is just a drug-coated balloon. So I like to apply the drug-coated balloon because I think the dissection is very minor and lumen is very large. So the dissection is located between the stent and stent. So dissection may not progress to the distal and may not compromise the LAD flow. In addition, I don't like too much metal strut in the LAD. So I like to apply the drug-coated balloon. Length is 30, 30 drug-coated balloon to cover the whole two bare metal stent ISR lesion.
I think that this is a good idea because from our study, we're showing that bare metal stent, in-stent restenosis treated with DCB and drug-eluting stents, actually the result is almost similar. But if you have a DS failure, of course, DS failure is more tended to be have a recurrent in-stent restenosis. So that would be another issue. But for the bare metal stent, in-stent, DCB versus drug-eluting stent would be both a good approach.
So this is the drug-eluting balloon, and this is
What
30
size of
seconds,
balloon?
3030.
3030.
So it takes 30 seconds.
Dr. Chang?
Yes, depilation.
Do you think the drug-coated balloon working for coronary intervention?
I think as Dr. Wu mentioned that in the BMS restenosis, maybe DCB is better, but I do not have a lot of experience with BMS restenosis.
Another concern is the cost, because why the European countries not that keen to use DCB, because DCB is 1.7 higher price than the regular DS. But I don't know what is about in Korea, because
it's similar in Korea.
Same in Korea, so it's DCB is somewhat higher price.
And especially in this case, we saw that there is under expansion of the BMS, so trying the BCB is worthy to treat this case, I think.
So mid to distal is endogenous stent by calcification. So we don't need a stent implantation.
So after high pressure balloon, we achieved enough stent cross-sectional area, and to prevent neo-intima hyperplasia, I applied a drug-coated balloon. I think this result is very, at best at this point, I think. I'm very happy to.
Nice.
Yeah, thank you.
It looks stent-like result.
Thank you. So I'd like to finish this procedure now.
Okay, thank you very much.
Thank you.
You did a really good job.
Okay. Let's move to the featured lecture of this session. There's a title of this live course. The lecture title is very simple: How PCI. From the lecturer is Myeong-Ki from Severance Hospital. His title is the Imaging Guided Approach.
Thank you, Dr. Chang.